All right, so let's talk about respiratory disorders. Now, the first 50 or so slides is all about the normal respiratory. This was one of those charts that you learned from A and P. I'm not going to go through it again, but we're going to use that later on. We got to know about the tidal volume and know about the total lung capacity and so forth. But we'll be using those terms. And you know all the abbreviations, like TLC is total lung capacity. It's all the usual classic abbreviations that we see. Okay? So we'll get back to that. So how are we breaking this all up? Respiratory disorders. Okay. First, I'm just going to talk about just general tests and terms of respiratory disorders. Signs and symptoms that you would normally get. All right? And then we're going to get into the diseases. We have obstructive diseases. These are the diseases that some way it's obstructing the airway. Like sleep apnea, asthma, emphysema, COPD. We're going to talk all about that for there. And then we have the restrictive diseases. These are the diseases that are restricting the lungs from expanding. So something's pressing down on it, okay? And we'll talk about ARDS, idiopathic pulmonary fibrosis, and so forth. And that's going to be a bulk. These two things are what we're going to be talking mainly about today. Then we'll get into vascular and circulatory diseases. This is the part that I said I'm not going to be going over with you here, but you need to know about in the textbook, because we already dealt with it before. This is the pulmonary embolus, pulmonary congestion, also known as pulmonary edema that happens with that, also pulmonary hypertension. It's all the same thing, okay? But just make sure we've discussed it. You just have to go through it, at least in the textbook, to add to your knowledge on it. Then we're going to talk about diseases of the pleura, all right? That's the coverings of the lungs, okay? And then we'll get into pneumonia and some other infections. And then lastly, we'll cap it off with lung cancer, all right? So that's how I kind of broke it down for you guys, all right? A lot there, but we got it all done. All right? All right, so let's look at the four components that will make up towards some sort of lung disease. So the first thing here is that there must be something wrong with the air sacs. Maybe that's the reason why the person's not breathing. So there could be something inside the air sacs, like water. Maybe it's some inflammatory process. Maybe it's something from, let's say, pneumonia or pulmonary edema. Something that's putting water in there that's allowing there's a thickness of oxygen that needs to get into the bloodstream, but there's that blockage of water that's in there. I got a picture to show you right after this too to make more sense. We could also say there's some kind of issues with the airway. Maybe there's something that the airway is just not opening up properly. Something's holding it down. Obesity can do that. Obesity is so much fat, there's so much adipose tissue that's pressing against the lungs. When you try to take in a deep breath, you can't because it's all pressing down. Something's restricting that lung to actually expand. There could be something wrong with the membrane itself. Right where the simple squamous epithelium is, it's supposed to be nice and thin. But if it gets thicker, then we're going to talk about this, where the sac gets thicker. Or it could also be right where the blood vessel is. A pulmonary embolus. We're going to have a blockage of oxygen that's going to the alveolus. Okay? So this is a picture that kind of puts it all together. This is what it would normally look. So you have the bronchiole here over here. It's going to lead to the alveolus. There's going to be a membrane around the alveolus. And then you have the blood vessel over here. So oxygen is going to come this way, pass through this very thin wall to get the oxygen into the bloodstream. Carbon dioxide can actually pass right through this thin wall and go this way. If this place gets blocked, or if this gets filled, or if this gets too thick, or there's a blockage over here, we have a problem. So if this alveolus gets filled with fluid, like edema, blood, pus, right, like in pneumonia, then we're going to have problems having that oxygen trying to get through all that thickness of the fluid to get to the bloodstream. We can have the membrane get really thick. And if it does, it's not going to be able to stretch properly. Something's holding it. Something's restricting it from doing that. That's what's happening with the membrane here. Or there could be something going on in the bronchiole. Something where it's collapsing. There's some kind of airway blockage over here. Whether it's simple as a foreign body in there, or the walls of the bronchiole kind of collapse and that kind of blocks the airway over here. Or there could be something wrong with the blood vessel. If blood is supposed to go this way and there's an embolus over here, now blood can't get into that area, so the oxygen can't get into there. So when you study pathophysiology of the lungs, think of these 4 different components. It's got to fall into one of those 4 components why the person is not breathing. It could be a combination of this, but always it's got to be one of these, at least one of these 4 things. All right? It's trying to organize your brain to figure out what's going on, the pathophysiology. Okay? Questions on that? All right, so let's just run through some tests and some terms of just these respiratory disorders that we use in these words throughout the whole presentation. We've got to first talk about elasticity versus compliancy. Some old stuff from A&P, but I think it's important for you to understand it. Elasticity. When you take a rubber band and you stretch it, that's not how elastic it is. If a rubber band, when you want to say a rubber band is very elastic, being able to stretch it is not elasticity. That's how much it can, well, that's compliancy, how well it's compliant. Elasticity is when you stretch it and let go, how well can it actually go back, a recoiling action. That's elasticity, okay? So if you take a balloon and you blow it up, and a normal balloon, it's easy to get the air in. So if you take a balloon and you fill it up with air, and then let go of the nozzle, all that air should go out. All right? If all the air goes out, it has good elasticity. Okay? It's not how well it can stretch. That's compliancy. How well it recoils is elasticity. And for a person who has emphysema, which we will talk about extensively in a moment or so, but if someone's got emphysema, what happens here is that their lungs are overly inflated. It's like taking a balloon and blowing it up 4 billion times, and now you look at the balloon and it's all baggy and flabby because it's been blown up so much. It lost its elasticity. So now, when you blow into it, it is so easy to get air in there, right? So you can even ask like a 3-year-old, can you put air in here? You'll have no problems getting air in there. There's no problems getting air into the balloon. But when you fill up that balloon, it actually will get bigger than usual, wouldn't it? Because it's baggy and flabby, right? So now you got this big balloon, and when you let go of the nozzle, the air comes out, but not all the air comes out. There's still some air trapping in there. So you've got to use your accessory muscles. You've got to be able to use your muscles of your arms and push out the rest of the air. So in a patient who's got emphysema, they will have problems not getting air into their lungs, but getting air out of their lungs. They're going to have to use extra muscles to push out that air. They have a lot of air traffic. Their lungs are massively big. We'll talk about why that happens with people with emphysema. All right? So if you decrease elasticity, think of that old, overstretched, flabby balloon. Air is easy to get in, but getting air out is very difficult to get all that air out. Are we okay with that, understanding that concept? Okay. So let's talk about the opposite, compliancy. This is where you take an elastic band and you could stretch it and you can let go of it. If it's easily stretchable, it's got good compliancy. Okay? But if you take the rubber band and like you can't really, it's supposed to go out to here, but you only get it out to here. It's got poor compliancy because it's not able to stretch. So, my analogy for this is, you ever see those balloon animals, or those balloons to make balloon animals like the clowns do, and you make those long, narrow balloons, you know what I'm saying? And you fold it up, you make a dog, or you make a snake, or whatever. Well, snake's pretty easy, but, all right? But that's what that, so I still can't do that. I can't get air into those friggin' things, all right? I don't have the lungs to do that. So in that case, there's a lot of elastic fibers around those balloons that it's difficult to get the air in. Does that make sense? Right? You know what balloons I'm talking about, right? All right? Maybe I should have had 2 here as a visual sample, but I wasn't going to do it for you guys. But it's hard to get the air in. But once the air is in there, you let go of the nozzle, that air comes out very fast because it has a lot of elastic fibers. Okay? Now, we have a disease called idiopathic fibrosis. When this happens, now it's idiopathic, so we don't know why it happens. But what happens, what happens, we don't know why. But what happens is they produce, the fibroblasts start building up all around the lungs, and they start producing a lot of elastic and collagen fibers that start surrounding all the alveoli. So now you've got all this extra, you want to call it scar tissue, because that's basically what it is. You're putting a lot of collagen and elastic fibers all around the alveoli. So now when it tries to open up, you can't, because there's so much scar tissue all around there. So these people with idiopathic fibrosis, it's difficult to get the air into these areas. But because there's a lot of elastic fibers, when they want to exhale, all that air comes right out, whatever's in there. But they can't fill it up because it's hard to inhale. Okay? So questions about the two, compliancy versus elasticity. And you can see we're going to be using these words quite often throughout the rest of this area. So just understand those the big flabby balloons versus the balloons to make balloon animals. Okay? Questions on that? Okay. Now, obstructive diseases. Obstructive diseases is a disease of the lungs where anywhere in the airway, and I use the abbreviation AW for airway because I use it quite often, well, anywhere where the airway is being blocked. It can be a multiple different things, okay? But like I said, air is easy to get into the lungs, it's hard to get out of the lungs. So there's something wrong with the elasticity. The compliancy is wonderful. The elasticity is not. So you're going to look at think of the air stays in the old flabby balloons. Okay? So we could have a lot of different things causing it. A foreign body, a tumor, a mucus plug, some kind of literal something that's blocking the airway. Could be increased resistance to the airway, so bronchitis can do that. Okay? Increased tendency for airway to close, asthma, and emphysema. So you have something like this in bronchitis. I'm going to make it very simple for you to understand, but here is the bronchiole, and this is an alveolus. You normally have the wall of the bronchiole like this. Air can get in and out of there, no problem. But if the bronchiole gets inflamed, it's kind of like doing this. Now look at how narrow that is. It's now being obstructed. Does that make sense? All right? In a way that we have like emphysema, what happens here is that it's so baggy that some of the walls of the bronchioles are kind of like falling into there. Air can get in, but it kind of acts like a valve. It's hard to get the air out. Does that make sense? So anything that's going to block the airways, well, that would be obstructive, as the name implies. Okay? Now, remember I showed you that chart earlier about the total lung capacity and the tidal volume. That's where these are over here. So there's an increase in these areas over here. So just go back on that chart, and you'll see what actually, and it would make sense if you understand how emphysema works. Restrictive diseases is anywhere in the airway or chest where the wall is going to be stiff. Like I said, obesity is a good example of this. It's going to compress the lungs. So it's going to be difficult for you to fill up your lungs. You're being restricted to get air into your lungs. Something's holding it back, okay? So it's difficult to get the air in. So think of those balloons to make balloon animals. It's hard to get the air in. It's easy to get the air out, though, okay? So you have stiff lungs. Idiopathic fibrosis was my example on that. Obesity can cause that. We have a stiff chest wall, okay? Also, you have respiratory muscle weakness. So the diaphragm is supposed to go down, right? And when it goes down, then these lungs could expand. But if you have multiple sclerosis or Lou Gehrig's disease, maybe that diaphragm is not going to work as efficiently as before, so it's not going to come down, so it's going to stay up there, which means it's going to restrict the lungs from expanding. So think of anything that's going to restrict the lungs from expanding as a restricted disease. So most of the diseases that we're going to talk about is going to fall into two categories, either obstructive diseases or restrictive diseases, okay? And for restrictive diseases, you're going to get these changes over here, okay? All right, so let's talk about pulmonary function tests, PFTs. Now we need to assess how much air is going into that person and how much air is coming out of that person. So we're going to do these tests over here. So we do this thing called spirometry, and we use a spirometer to do this, an instrument, which I'll show you what it looks like. But it's going to measure the amount of air going in and out of the lungs, and it distinguishes between these two groups of diseases we just talked about, obstructive diseases and restrictive diseases. All right? Obstructive diseases is anywhere where there's going to be resistance to the airway, anywhere where there's going to be an obstruction in the airway, whereas restrictive diseases is anywhere that's going to restrict the lungs from expanding, okay, to filling up with air. Most of all the diseases in respiratory fall into these two categories, okay? And this test, this pulmonary function test, is going to determine, is it an obstructive disease or is it a restrictive disease? And then it doesn't tell you which one it is in terms of, let's say, okay, it's obstructive disease. Was that emphysema? Is it asthma? It's not going to tell you that. It's just going to break it up into these two. It's almost different but analogous with gram stain for bacteria. Because you know that all bacteria is either gram negative or gram positive. Once you do the gram stain, you can narrow it down to what's going on here. Same thing with this, obstructive versus restrictive diseases. Okay? So this is what we do. Did you guys do this here? A lot of schools do this in their labs of A&P. You didn't do it? You didn't do it? Did you?
I didn't do it here, but I did.
You did it at the others? Yeah. Okay. And I did it too with two of my other schools. But what it is that you're going to take this machine and you're going to take a deep breath and you're going to blow into it 3 times. All the way, breathe all the way in and out. And it measures by using this little graph over here, so that you could actually see what's happening, how much air is going in and how much is going out. And then you can decipher around here. Why do we put this thing on your nose? Cheat, how? Right, right. You see, the thing is, you want to collect 100% of the air going in and 100% of the air going out. It's not that you're cheating, it's just that you can't help it, but when you blow out, maybe 20% of the air is going to go out your nose. That's not going to help you over here. Okay, so that's why they do that. Okay? So we do a total ventilation going on. Okay? We need to know how much air is going in and out of that person in 1 minute. So we have 2 different things over here. There's a formula that's pretty easy to manage. All right, you'll need to know how to do it, but it's very easy. Okay, it's kind of like the ejection fraction, very easy. You just need to know what the terms are. But a forced vital capacity, FVC, what that is that you take a deep breath and you blow out as fast as you can all the air that you could take out. So you take a deep breath and blow it out. All of it. That's a forced vital capacity. Then we have something called a forced expiratory valve. They usually have like a subscript number 1 over here. All right, kind of looks like that. What this does is that 1 tells you how much of this air actually came out in the first second. So I'll do that again for you. I want to show you what's going on. Blow it off. All right. Now that took about 4 seconds to do. But what they want to know is in FEV1, how much came out in the first second? All right? And it looked like a lot came out in the first second. So how do you put this together? Okay, we have this little index, the Tiffany-Pinelli index, and it's very easy to manage. Okay? You just do FEV1 over FVC and you got a percentage. So I'm just going to give you numbers so it's easier to manage, all right? So you can see what's going on. And I'll give you the real numbers. Let's say I do that blowing, so I take a full blow and, okay? And let's say, I'm just making numbers very easy for you. 100 milliliters of air came out. So that's my forced vital capacity. That's how much all the air came out. Over 4 seconds, that's how much came out. But in the first second, 80 milliliters came out. Does that make sense? All right? Because most of it came out in the first second. So I'm just saying, let's say 80 milliliters. So then what's the percentage? What's the percentage? If this is 80 and this is 100, 80%. All right? So what does that mean? What does 80% mean? Well, this is predictive of normal value when we put down things like your age, sex, weight, height, and believe it or not, even the ethnicity. But also, if you're a smoker or was a smoker, all this you got to plug in there. But what does it tell you? These are the magic numbers you need to know. If you get something between 70 and 85, that's normal. If you have less than 70, that's going to be severe obstructive disease. And if it's greater than 85, then it's restrictive disease. So I don't want you to memorize that. I want you to understand the concept. So put your pencils down, and I'll do this graph for you, because it's very easy to understand. Disregard these two over here. Let's just do this one here for you. All right? And it'll make sense. This is time. And this is liters of air that actually went in and out of your lungs. Okay? Or let's say, well, out of your lungs. So you're going to blow out, so you're going to take a deep breath and blow it out. All right? Does that make sense? I blew out all that air. So I blew out 5 liters in, let's say, 5 seconds. Not 5 seconds. Probably about 3 seconds. All right? So what they did here was that 5 liters was how much I blew out total, FVC. Okay? And then how much came out in the first second? Well, the first second, it looks like about almost 4 liters came out. You see how I got that? All right? So then you're just going to do 4 divided by 5, and you got 80. And that's normal. Do you see how I got those numbers? I know when I put graphs up there, these are the same ones that I used for my A&P2. So I'm teaching the same stuff to you that I taught my A&P2. Same exact things. Okay? So I know when people look at graphs, they're like, ugh. All right, but does this graph make sense? Okay, well, let's look at someone who's got obstructive disease. Someone like emphysema, a big baggy balloon that's hard to get, it's easy to get air in, but it's hard to get air out. Okay? So what they're going to do is they're going to take a breath, and it's hard for them to they get the air in, but when ask them to blow out the air, they're not going to blow out everything. There's going to be air trapped in there still. So they'll blow out the air very long. Now their lungs are big, like an old flabby balloon. And they only were able to blow out, let's say, about 3 liters. In the first second, since they had a very long expiratory volume that came out, in the first second, very little came out. They have problems getting air out. Only about 1 liter came out. When you put that together, and their percentage would be 42%, which is very low. Does that make sense? You see how I got those numbers? Okay? Then let's look at somebody with restrictive disease. Someone with obesity, someone with idiopathic fibrosis. Okay? So what happens with this person, they're going to blow out air. They're going to take a deep breath and blow out air. Now, I'm going to do it very fast. But they are only going to blow out, let's say, almost 3 liters. Similar to this, but for different reasons. They have problems not getting air out. This person doesn't have much air in their lungs because it was so tough to get it in there in the first place. So they blow out and very fast, and about 3 liters. And in the first second, because the air comes out very fast, most of it is going to come out in the first second, much more than it would be for a normal person. So 2.8 come out. So in this case, their percentage is going to be 90. Does that make sense? And this is what spirometry is all about. That's where we're getting the numbers from someone who has severe obstructive disease. It'll be very low, the percentage. With someone who's got very, or let's say a restrictive disease, it's going to be very high. Does that make sense? Good? You know how to apply this stuff, right? So I might give you something on a test question. I might ask you, here's the numbers. Is this going to be restrictive or not? And you've got to put together the formula and figure out that whole thing. Right, it's not hard to do. Okay? Okay. So let's now change gears a little bit. Let's talk about some breath sounds. Okay? I know you guys haven't listened to the breath sounds, but I think you should know the terms of breath sounds and what they should sound like, so that when you do clinicals, I guess next semester, so at least when they say words like crackles and reels, you have some idea what that's all about. So we have something called cleared to auscultation, or CTA. That kind of just means that you listen to the lungs and it's clear. There's no abnormalities in there. I can hear air going in and out. This is the way hopefully you and I are sounding, all right? There's no abnormal breath sounds there, okay? Then we have something called rails and crackles. Rails and crackles is this crackling or bubbling sound. And it's not so much for you to understand the difference between wet and dry. That's later on. I kind of put that up there to be complete. But it's telling us that there's probably some kind of water in there, some kind of congestion, pneumonia. Now, crackles sounds like, the best way I could explain what it is, if you take the hair from your ears, or from, not from your ears, but near your ears, and you rub your hair together, that crackling sound, that's what crackles sound like. Just rub that, you know what I'm talking about? Just rub that, okay? But it's not up here you're hearing it. Remember, you're hearing them down in, well, anywhere in your lungs. And that's what crackles are. And some people call them rails, all right? You also have something called rhonchi. And this is more of a humming or whistling or snoring sound. But not up here. I'm doing it up here so you can hear it. But we're talking about in the lungs. And that's usually telling us that there's some kind of foreign body in the bronchus, that there's a lot of mucus in the bronchus. Okay? The first thing you say if you hear crackles or you hear bronchi, ask the person to cough. Because a lot of times they have some fluid down there that's just there from, I don't know, just normal fluids. So you ask them to cough and then they clear up. So it's kind of like just an artifact. But if you suspect someone pneumonia and you hear these, then that just means it might be confirmation for you. Okay? We also have stridor. This is not a sound you want to hear. Stridor is this harsh kind of high-pitched barking seal barking. All right? Like that kind of sound. Again, it's not up here, it's down here. But it could be really bad that you're going to hear it up in the upper area. right? The upper respiratory area. This is not a sound you want to hear. This is a sound that the epiglottis is blocking because it's so massively enlarged and inflamed that it's blocking the upper airways. 3 o'clock in the morning, you hear your baby brother doing that, hur, hur, hur. Oh, he's just doing that, probably going through a nightmare or something. No, go in there, because this will save lives, okay? You might have something, you might have croup, right? You've heard of croup. Croup might be the reason why he's doing that, and you've got to bring him to the hospital to clear up that whole area, okay? We also have wheezing. This is a high-pitched sound that's going through, it's air trying to go through a very narrow passageway. Classically, the asthmatics have this. I'm doing a lot louder so you can hear it, all right? But a lot of times, you don't hear it up here. You hear it in the lungs. All right? If you hear it up here, then that's massively bad. That's so bad that it's reaching up on the top. So we have to keep an eye on that, okay? But that's wheezing. Then you have this pleural friction rub. We talked about that with pericarditis, where you have a friction rub. But that for pericarditis is that we hear it on the heartbeat. You hear this almost like stepping in snow, right? I explained that before, right? Stepping in snow. In this case, it's not with the heart beating. It's actually asking the person to take a deep breath. And it's like you're stepping so, boom, 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 right? That's what a pleural friction rub is, and that's saying that but the pleural cavity, the two layers, the visceral and parietal layers, they're so inflamed that they're rubbing against each other and making that friction kind of sound. Some people say it's like a Velcro kind of sound. I like to use the word like stepping in snow. If I was in Hawaii, I guess I would have to use the word Velcro, but we're not there yet. All right, so any questions on that? That's usually pleurisy that usually causes this, or pleuritis. It's the same thing. Okay, so common signs and symptoms of respiratory diseases, all right, that we'll be using throughout the whole thing. Dyspnea, right, we talked about that, short of breath, difficulty in breathing, all right. Apnea, if you have, let's say, the A, Nia means breathing, so you have A, so it's without breathing, okay? So period of cessation of breathing. You can also have hypoxia, inadequate oxygen to the tissue. You can also have hypercapnia, which is that there's an increased levels of carbon dioxide in the blood. All right, so you'll see these words often. I don't know why it show up like that. Let's see. Asphyxia is a fancy word for suffocation, right? You're not getting any intake of oxygen. Someone's choking you, kind of thing. All right, but not just that. I mean, you can have a seizure, and then your muscles in your throat kind of clamp down, and that also causes asphyxiation, right? You're not going to get air through there. Tachypnea is breathing that's going to be greater than 20 breaths per minute at rest, okay? And then bradypnea is where the breathing rate is less than 12 breaths per minute at rest. Remember, this is at rest, all right? I wouldn't call this, if I'm running, let's say, a 20-mile marathon, I'm going to breathe faster, okay? Orthopnea, we talked about this one too. This is where you have problems breathing while lying down, right? So it's short of breath. It gets relieved when they're sitting up. It's because usually you got pulmonary hypertension that just floods all that extra edema in the pulmonary system, kind of floods the whole area, and it's difficult to breathe. So when you sit up, all the water in the lungs will actually go down to the lower areas. This is common in heart failure. We also have paroxysmal nocturnal dyspnea, and this is the same thing as this. The only thing is that it's so bad that they have to sleep on. Oh, I'm sorry. This is so bad that they wake up in the middle of the night because they can't catch their breath. All right. So that's what happens over here. So they usually go to bed. They say that they need like 3 or 4 pills to sleep on. It's always a good question to ask them. How bad is the breathing? Do you need to have like 3 or 4 pills? Like how many pills do you sleep with? Sometimes they just say, well, I just need like 2 pills to sleep on because it's very comfy. But ask them, if you didn't have that, would you have problems breathing? All right. So don't just take their word for it, or expand a little bit of what they're of why they're doing that. Okay? You might have better clues to figure out what's wrong with them. All right. Dysphonia is hoarseness, all right? If we have lung cancer that invades one of the recurrent laryngeal nerves, which give innervation to your voice box, that can cause hoarseness, okay? You can have aphonia, where it's a loss of ability to produce any kind of sound at all. You have dysphagia, that's a difficulty in swallowing. Hemoptysis is coughing up blood, and we also have sputum production. Now, let me just talk about very briefly what sputum is. Because it's very important when you're in the hospital and you ask the person to give you a sputum sample. First of all, don't ask a patient for a sputum sample because they don't know what that is. Okay? They will just usually spit into a sputum. Sputum is down deep into your lungs. That's what you want. You don't want the saliva. You want this stuff down here. Now, you and I can't produce sputum. We just have a normal amount of sputum down there that is too thin for us to cough up. But if you have pneumonia, believe me, it'll be very easy for them to cough up that you might call it phlegm, but it's coming deep down. They'll know exactly what to do. But that is loaded with bacteria in the lungs. That's what you want to culture. You don't want to culture the saliva that's in the mouth. So make sure when you ask for sputum or phlegm that you talk to them and I need to get that deep down fluid that you have in there. They'll know exactly what you're talking about. When you have pneumonia, you'll see what I'm talking about. It's easy to produce that. Okay? All right, clubbing. It's not what you do in New York City. Okay? Clubbing. This is kind of a weird thing, and we don't have any reason for it. I mean, in the sense of we don't know why it does this. The fingernails, the fingertips kind of bulge out. They call it clubbing because they kind of say, well, you know, if you got like a drumstick, it kind of clubs out over there. Does that make sense? When you do this kind of thing? I guess that's where they come up with that. But clubbing, we're not too sure why this happens. That's why I look at people's hands. Clubbing has this thing where normally there should be an indentation there. All right, you see it over here. But in clubbing, a club finger, it's actually the angle where the indentation of where the nail is actually is going to be greater than 180 degrees. Now, what causes this? We don't know. But we know it's associated with a lot of different diseases. Diseases of the lungs, cystic fibrosis, pulmonary sepsis. There's a lot of different things that would happen here. Diseases of the heart, right? Bacterial endocarditis and cyanotic congenital heart disease, like tetralogy of Fallot and stuff. Cirrhosis of the liver, certain kind of inflammatory bowel disease, which we'll talk about later. But we also have this too, congenital clubbing. My senior resident, when I was a junior resident when I was working as a doctor, my senior resident had that, but he was born with that basically. So keep in mind, you always gotta ask them. I noticed those, I saw your fingers over there. Were they always like that? No, I never really noticed that. A lot of them, because they look at their nails all the time, they don't see that. So if that's something that's new, chances are there's a disease that's brewing in them. We got to figure out what's going on there. Okay? But if they always had it, then chances are that's not caused by a disease. Okay? So that's why I look at people. I look at your hands, I look at your eyes. I know what you have, I know what you have, I know what you have. But you just get when you get into the medical field, you'd be just forced into just looking at people and getting ideas of what's going on.